Welcome everyone to this webinar. We're just going to wait another minute or two while more people come in. Okay, well, I will get us started. Next slide, please. So my name is Theodora Swift-Kohler, and I'm Senior Technical Advisor for Health Equity. And I'm here today chairing this webinar together with my colleague, Evelyn Boimena, who leads our gender work here at WHO headquarters. Next slide. And we'd like to welcome you very warmly to this edition of a webinar in the series for rural health equity. And this is the 7th webinar in the series, and it's specifically focusing on rural women and addressing inequities in health service coverage. This webinar series is jointly convened with Wonca, as well as different UN agencies that are part of the Inequalities Task Team Rural Poverty subgroup. This webinar series is also linked to the overarching campaign of WHO for World Health Day 21 on health equity. Next slide, please. In today's webinar, we have a great panel lined up. We are joined by Majaliwa Marwa from UNFPA Tanzania. We are joined by Ahmed Rasa from FAO, by Chemtai Mungo from the University of North Carolina in the United States, by Mark Emerson from the University of North Carolina as well in the United States, Ozdin Gökdemir from the Izmir University of Economics in Turkey, and also Bruce Chatter from Wonca's Working Party on Rural Practice. Next slide, please. So in the overarching approach that we are taking with this webinar series, we very much are looking at how health inequities in rural areas are the result of adverse social and economic determinants, as well as weaker health systems. And in the presentations that you'll hear today, you'll hear about different health system performance deficiencies that are occurring in rural areas, but then you'll also hear about very important social and environmental determinants of health that are compounding and influencing the health of rural populations. With that, next slide, please. I'd like to hand over to my co-chair, Evelyn Boimena, who's going to say a bit more about the topic of this particular webinar and its lead up to International Women's Day on the 8th of March. Over to you, Evelyn.
Sorry, just having trouble unmuting myself. Thank you very much, Thea, for the wonderful introduction. My name is Evelyn Boimena, and as Thea mentioned, I am a gender technical officer in WHO. To start us off, in 2020 and 21, a quarter of a century after the Beijing Platform for Action, the global community took stock of progress made toward gender equality and the empowerment of women and girls. And in this context, the Interagency Network on Women and Gender Equality developed the review that you see here on this slide to raise awareness about and promote opportunities for rural and Indigenous women and girls. Now, it's no secret that progress in empowering rural and Indigenous women and girls has been slow and uneven across regions. And we know that rural women and girls are among the ones left furthest behind and face multiple intersecting, compounding forms of discrimination that influence their health, but also health service coverage and their access to it. Rural women and girls are not a homogeneous group, of course, but they do face similar obstacles and concerns. A critical impediment is their access to health and other social services by rural women and girls is that they are at a higher risk than urban counterparts in lacking a birth certificate due to weak civil registration and vital statistics systems, which results in being systematically excluded from benefits tied to a birth certificate and prevents them, especially as children, from being counted in national health data. Furthermore, many rural and indigenous girls and young women face massive barriers in agricultural labor markets and are restricted to low status, poorly paid jobs without legal or social protection or access to essential services and adequate healthcare. So this is, of course, means that there's no surprise that 3/4 of those living in poverty and facing chronic undernourishment reside in rural areas. Compounding this, gender discriminatory behaviors and practices are commonly shaped by social cultural norms regarding the roles that are played by women and girls, men and boys, and result in rural women often having less access to and control over productive resources, technologies, services, and opportunities than men. And as a result, and in addition to this, they tend to also lack self-esteem, confidence, and negotiation and leadership skills, or what I'm referring to in this slide as agency. And as a result, also have lower education levels than male counterparts, and also continue to face gender-based violence in their homes, communities, and the workplace. And in particular, because they lack access to land, productive resources, public services, and infrastructure, all of which compromise their capacity to, this compromises their capacity to withstand extreme weather events and the effects of ongoing climate change, which brings me to the topic of my next slide. Thank you, Pramila. Which is to do with the theme of International Women's Day this year, which is around climate change and sustainability. And the slogan and theme for this year is Gender Equality Today for a Sustainable Tomorrow, recognizing that despite the multiple constraints that rural women encounter, they are major agents of change, resilience, and sustainability because of their capacity, their local knowledge, and their enterprise skills. And while they are often having to adapt their production systems in response to climate change and natural resources depletion that also affects their health and health coverage, as well as their access to health, we know that when rural women have equal access to education, to skills development, to services, productive inputs, and employment opportunities, they are more protected from discrimination, gender-based violence, and that the yields on their farms increase. And this contributes significantly to economic growth, food security, and nutrition as well. And in an enabling environment, they're leaders in their communities and businesses where they provide sustainable and innovative solutions to local as well as global challenges, including the right to health and health coverage. So with that, let me go to our first presenter and begin our panel discussion. I would like to introduce Dr. Majlawi Marwa, who works to ensure that program quality, its efficiency, and effectiveness of the UNFCA's support to the government of the United Republic of Tanzania within the context of the UNDAP 2. Specifically, this focuses on UNFPA's thematic area of gender equality and human rights, which builds building and managing partnerships and coordinating the work of UNFPA in the field. Dr. Mayilawa is also coordinating a Ujana Wangu Nguvu Yangu project, which is a 4-year project focusing on improving access to sexual reproductive health and rights to adolescent and young women in rural areas and in humanitarian settings. Today, Dr. Marwa will present on improving access to ASRHR to first-time young mothers in rural areas in Northwest Tanzania. Dr. Marwa, over to you.
Thank you very much, Evelyn. And good afternoon, everyone. As Evelyn said, I work for UNFPA, and basically today what I'm going to share with you is an initiative which is part of our project to improve access to adolescent sexual reproductive health and rights to first-time young mothers in 5 districts in rural areas in Northwest Tanzania. Next. So to give you a bit of a context, Tanzania has a population, a very youthful population, with nearly 44% of the people below the age of 15, with very high age dependency ratio of 92%. The sexual reproductive health indicators are not doing very well. We have very high teenage pregnancy of almost 27%, high adolescent birth rate, HIV prevalence rate is also high, also compounded by high school dropouts, with which is contributed mostly due to child marriage and teen pregnancy. Generally, coverage of services is also unacceptably low, with very low coverage of comprehensive sexuality education. Availability of youth-friendly services is also low, with only 1 in 3 health facilities able to provide the services. And generally, young people do not have the opportunity to participate in making decisions, in decision-making platforms where decisions are made about their future and their well-being. Next. In this slide, I wanted to zoom into the Kigoma region. This is a region in the northwest Tanzania where we are implementing our project. Kigoma is one of those regions that has been a home to, historically a home to refugees from the most countries along the Great Lakes. I'm on the right here, I tried to show you the map. So Kigoma is right along the Lake Tanganyika, which is serving as the border of Tanzania to partly Rwanda, Congo, Zambia, and to the north, there's also Burundi. So historically, this is a region that has been receiving refugees, and these numbers of refugees coming to Tanzania has added pressure to the already weak health system in the region. It is one of the poorest regions in Tanzania. Again, the numbers are not different. High population of young people, very high teenage pregnancy, with majority starting sexual activity before the age of 15. Very limited knowledge on HIV prevention, with only 21% of young girls of 15 to 25 years in our last population and demographic health survey could identify correctly ways of preventing themselves from HIV transmission. Next slide, please. So a bit about the project. This is a 4-year project funded by the Irish government with approximately 4.5 million euros. It has 2 major outcomes. The first outcome focusing on empowering young people to exercise their sexual reproductive health and right and fulfill their potential. So basically empowering them to demand for services. And the second outcome is focusing on improving access to utilization. So mostly working on the supply side of the health system. We are aiming to reach around 24,000 young people, 10 to 24 years, and nearly 82,000 pregnant women, and more than nearly 300,000 secondary beneficiaries who are women of reproductive age. We are currently on our 4th year of the project, and we are hoping to complete this project by June this year. Next. So now I wanted to focus now on the first-time young mothers. Why did we choose to focus on first-time young mothers? So maybe to talk again a bit about the project. So the project has, as you've seen, 2 outcomes and several outputs. And one of the outputs specifically focuses on first-time young mothers. We have other outputs focusing on other issues like the health system, gender equality, and improving issues around gender. But then we also have an output that is specifically focusing on first-time young mothers. And the reason for this is that we understand, we have an understanding that this group of population in Kigoma is already vulnerable and marginalized, and at further risks of pregnancy-related complications, emotional and psychosocial issues, sexual and gender-based violence, but also the cycle of poverty and inequity that could go on from one generation to the next. And this is not only for Kigoma region, but for this particular project, we focus on Kigoma based on the fact that it has a huge population of young people. It is the poorest region, but then the health system is also weak and further compounded by the influx of refugees, which as we speak now, we have more than 150,000 refugees in this region. And most of the districts where the project is implemented, 4 out of the 5 districts, they have refugee camps in those districts. Next. So the project took an approach of looking at the whole sphere of influence. So we looked at the individual level way up to the health system, recognizing that at individual level, young parents, these first-time young mothers, they have limited knowledge and resources that can enable them to seek health services. But again, at couple and family level, there are relationship dynamics and gender norms that may work against these young people to use sexual reproductive health services. Higher up at the health system level, we recognize there are several challenges. The health system, as I said, is already weak and not well equipped to provide services that are tailored to the needs of these adolescent and young people, and particularly first-time young mothers. Next. So the project have 3 pillars. The interventions have 3 pillars. So first, focusing on the service delivery and access, where we are working to train, we've been training healthcare workers on sexual reproductive health, various elements of sexual reproductive health, but also the psychosocial needs. We have worked also in refurbishment and the equipping of maternity wards to improve the quality of service provided and cater for this group. We have also worked on strengthening the referral system, but we're also looking at availability of commodities and supplies. And then the second pillar is mainly focusing on information, knowledge, and empowerment, trying to make sure that these first-time young mothers have information, have the knowledge, and are empowered to actually demand for services, to mobilize themselves, and also reach out to their peers to create demand for services. And last pillar is on the community approach, where we are focusing on ensuring that we are creating an enabling environment where first-time young mothers can be accepted in the community, because we understand once these young girls got pregnant, some of them, they face hardship at where they are living. A majority are forced to leave school. So we wanted to have a community that is supportive, that understand the challenges that these girls are going through, and are able to support them to take care of their children, but also to access services and other social services. Next. So far, we have refurbished and equipped 17 maternity wards. We have also reached more than 1,000 first-time young mothers with sexual reproductive health information. Overall, more than 27,000 young people have been reached with services. We have sensitized and create awareness to 174 community members. These are community leaders, so some of them coming from the faith-led organization, teachers, parents. But we've also trained more than 42 healthcare workers on youth-friendly services, how they can provide services in a friendly manner to these young people. We have established 24 groups of first-time young mothers who act as peer educators. And in each group, we provided them with bicycle and smartphone. This will enable them to be able to do follow-up of their peers, to do outreach, and contact some of their peers to ensure that they're able to refer them to services. And lastly, these peer educators, these first-time young mothers were trained to become peer educators, and we have more than 100 of them working as peer educators. And as you can see on the photos on the right side, these are some of the groups of young mothers at the top, but also one of the maternity ward that we have refurbished, and a group of young mothers receiving their bicycles. And maybe to talk a bit about the maternity ward. So these are at the lowest level of the health service provision. So at the dispensary level, because we understand that this is at the level where accessibility to service is a problem. These are mostly in the rural areas, hard to reach, and this is where we focused on ensuring that the infrastructure is available to provide high quality and comprehensive services. Next. So over the course of implementation, there are a number of lessons that we have learned. One is that the problem, the substantive need and the magnitude of the issue, and also the degree of vulnerability of these first-time young mothers in this region. But they need to have a tailored intervention to respond to specific needs and demand of these young girls. Also the issues around structural and social causes such as poverty, gender-based violence, and lack of educational attainment. All these are interweaved into the problem of early pregnancy. So you need to be able to address specific issues along these dimensions. Third is that they need to be able to provide service that is of good quality, responsive, but also non-judgmental. Already these young girls have been judged in the society by getting pregnant. Some of them have dropped out of school. Some of them have been chased from their home. So they need services that are responding to all these needs, but also they shouldn't be judged again. The need for psychosocial response, because as I said earlier, that there are issues around isolation, stigma, and depression. Lastly, we also see the need of the role of peer support networks, how this can be central in ensuring that other first-time young mothers can be reached, mobilized in an environment that is safe, and that are able to access the services. Next. Yeah, so this is the end of my presentation. This is what I wanted to share with you today. I think later on I'll be able to respond to questions and also hear also reflection from from the participant. Thank you very much, and over to you.
Thank you so much, Dr. Marwa. It was really impressive to see that the intervention has reached 27,000 young people. That's quite expansive. And also the pillars that you indicated with service delivery and access, information, knowledge and empowerment, community approach, and the use of peer education as part of the peer approach or the community approach. It's a very comprehensive intervention with a focus on rural areas. So thank you so much for that. I'd like to now go to the next speaker. So this is Ahmed Rasa, who is a nutrition and food systems officer at the Food and Agricultural Organization of the United Nations. Since joining FAO in 2014, he has supported over 10 low and middle income countries in designing and implementing nutrition sensitive agricultural and social assistance programs and interventions. And his presentation today will focus on highlighting the importance of investing in nutrition related services for rural women to ensure an inclusive and efficient agricultural and food systems transformation in low income settings. So over to you, Ahmad, and thank you so much for joining us.
Perfect. Thanks, Theodora. And I'm really happy to be here. So what I will do is basically, I will split my presentation in two parts. The first part would be basically explaining the importance of rural women in the agenda of food systems transformation. And the second half of my presentation will be on the pathways or mechanism through which we can improve access to nutrition-related services for rural women. And in 10 minutes, I'll try to summarize as much as possible, but there might be some information which if you're interested in, please do email me, or if the slides can be shared afterwards, there are some links to sources, so you'll have information there. So let me see if I can work this. Okay, right. So I'll begin first by sort of setting the context. So I'm coming at this topic from a food systems and agriculture lens. And what you see here is basically a schematic of what a food systems can look like. It's a conceptualization which was worked upon by the high-level panel of experts at the CFS. CFS is the Committee of Food Security. And basically what you see is that food systems is composed of three main parts: food supply chains, food environments, and consumer behavior, all of which work together to improve diets and then nutrition. They are, of course, influenced by drivers, which you see from the top in blue, as well as policies and programs. And the point I want to make here is that rural women are an important part of this agenda, and achieving food systems transformation would not be possible without them. And to sort of make that point, more clearly through data, and I'll basically present some data which has been taken from FAO and ILO, is that women comprise over 37% of the world's rural agriculture force, and this number goes to 48% in some of the low and middle income countries. So essentially, women do constitute a main part of the labor force in agriculture and food systems. And also looking at the subsectors of agriculture, fisheries, and livestock, a similar situation can be seen. So 50% of the managers and fisher folk, for example, are women. Another important thing is that women are holders of knowledge, as was mentioned earlier, and they have information, for example, on not just production practices, but also, for example, tasks such as cooking and recipes which can be useful for food security and nutrition of the household. Despite this importance, they face major constraints, and these constraints are related to services, assets, and opportunities. And as you can see from the data on the right bottom side, is that women have less than 15%. Women still account for less than 15% of agriculture landholders in the world, and also compared to men, women are 10% less likely to own a mobile phone and 23% less likely to use mobile internet. Also, as was mentioned by Evelyn earlier on, even if women are more educated, they tend to be in low wage and part-time seasonal employment. And all of these numbers which are presented here are probably an underestimate, because a lot of the time and energy which women contribute to the agriculture and food system space does not get accounted for in the data. An important thing here to talk about is the gender nutrition nexus. I think without which this discussion on nutrition would not be relevant. And what I want to basically make the point is that this gender nutrition nexus within rural areas and food systems plays out at different levels, and one is more the individual level. So, here is sort of thinking about the nutrition status and health status of women themselves. And then the fact that the nutrition status of women also determines the health and nutrition status of children and their cognitive potential going forward. We all know that nutrition deficiencies begin in utero, and then if a mother is malnourished, she's likely going to give birth to a malnourished child. Also, women's education on practices related to health and sanitation impact not only their own nutrition, but also that of children. And then this nexus also plays out at the household level. We know that in most contexts, women are the primary players who are involved in food preparation, distribution, storage, etc. And all of those skills and knowledge has an impact on households' food security and nutrition. Also, in some low-income places, females are the head of the households, and there is a strong link between low incomes, poverty, and malnutrition. So that nexus also plays out at the household level. And then at the societal level, and this was discussed in my previous slide, is that women have lack of access to resources and services as compared to men, which has an impact on how at the societal level we make progress towards food systems and agricultural goals. So what can be the pathways? And this would be, let's say, the follow-up to the second part of my discussion, is basically the overarching objective, therefore, has to be that we need to close the gender gap in services, knowledge, assets, and collective action, which rural women face if we are to make realistic strides towards, let's say, food security and nutrition at the three levels that I talked about: individual, household, and societal. So there are four pathways or options that I will talk about. There are, of course, others, but these are four which come to mind from FAO's experiences and having looked through some of the literature in this space. If you look at the nutrition literature generally within the food systems arena, you would find that there are three pathways which are often talked about. And one of them has to do with making social transfers nutrition sensitive and conditional to the uptake of services such as antenatal checkups, provision of supplements, etc. Another pathway is on knowledge, so which was also in my slide earlier, that having access to knowledge on what to cook, how to cook, what are the feeding practices related to childcare are an important predictor of how the nutrition status of both the women and children will change or not. Women's economic empowerment is another pathway through which we can ensure food security and nutrition at the household level. And then fourth is collective action. So what I will do now is, for each of these four, I will present an example which can help illustrate this case. So to talk about social transfers, and basically the figure you see on the right is trying to place the different social transfers in the food systems framework. So for example, you would see food supply chains, food environments, and consumer behavior. Different social transfers programs can typically address or, let's say, influence each of these blocks. And social transfers can be of different nature. It can be cash transfers, food transfers, school meals, etc. But they have gained a lot of prominence lately. And one feature of these social transfers, and if you think of cash transfers, for example, is that they often include soft conditionalities, or they include interventions which encourage beneficiaries to attend, let's say, trainings or health services, and that can be a nice way to improve the nutrition status, improve knowledge, as well as to provide access to women of cash, which they can use to improve the economic and health of their household. But another thing which these social transfers can do is that they often have assets transfer as part of their programs, and which can support the improvements in water and sanitation facilities, which are an important part of the undernutrition world, because underlying causes of child undernutrition includes poor sanitation and access to water sources. So these social transfers can also help there. One thing that I would like to highlight is that there might be some contexts where providing access to cash to women may not work, because it could be the case that those settings are quite discriminatory, and there's a lot of gender inequality. So having control to money necessarily won't lead to changes. The second thing I'll talk about is the knowledge pathway that I mentioned. So this is taken from one of the FAO programs, which was conducted in Laos, which was done in collaboration with the Italian government. And the context was that there was chronic malnutrition, which was quite high at 40%. Women had less access to assets. And the project essentially, what it tried to do was it tried to improve the knowledge and skills of women in terms of production at the household level through integrated kitchen gardens. So to be able to support that, there was provision of inputs, seeds, and there were some households which were identified for small poultry production, and then they were provided information and training on how to process foods and create recipes which are both nutritious and save time. And the impact of this program was that the yields improved at the household level, and also the diversity of food generally available was improved. The third pathway, which I talked about earlier, was about economic empowerment. And here you see another example of the work from FAO's program in Bolivia. Basically, a lot of the food we consume comes from smallholder farmers, and most of the investments which are made in agriculture is also at that level. A lot of the food transactions happen in domestic markets in low and middle income countries. You see on the right a figure from Bolivia, and basically what you see is there that in organic farmers markets in Bolivia, where the study was done, most of them were women. They were not very educated. Most of them had primary education. They had less access to land, so less than 2 hectares. And then these enterprises were family owned. So this project sort of worked on improving women's access to these markets, one, and also making sure that there's infrastructure out there to be able to construct these territorial markets. And why is this important is because not all markets in low and middle income countries, domestic markets, are inclusive. There are imbalances to power, which exclude women from participating. So the point from this example is that having market infrastructure is not enough. You also need to be able to create networks and groups around which women can participate and improve their bargaining power at the market. Last thing, and very quickly, is about collective action. It's also coming from FAO's work, whereby which is called the Mitra clubs, which are basically informal groups where women and also men come together to talk about common problems and using local resources to sort of solve them. And this has been ongoing for about 14, 15 years in West and Central Africa. And it uses community and rural village setting as a locus. And the interesting thing here is that they use technology such as rural radios to be able to share experiences and network. My second last slide is on the gaps we still see. So there are still gaps we have in terms of development programs and research on the different domains of women's nutrition. So not just on undernutrition, but overweight and obesity and other health forms. We don't have enough information at the individual level. A lot of the information tends to be at the household level or level above. in the agriculture programs, there are very few studies which use women's empowerment pathway as a way of measuring nutrition. So there are some studies which do measure, but we have mixed results. Also, within cash transfers, I think we have limited information about how the programs sort of affect women's care practices during pregnancy and lactation. So there's a lot more work that can be done there. Last slide, and I'll finish with some key messages, and they're quite obvious, is that gender equality and women's empowerment is central to food security and nutrition, and also that women's access to resources and assets is not just important for their own health and nutrition, but also of the society and the household. And thirdly, that the programs from the research that I sort of did, it came out that the programs and investments tend to be successful if they promote coordination, if they have some aspects of community engagement, uptake of technology, and there's a sense of sort of forming coalitions and cooperative which can improve their power to engage. So with that, I'll finish, and I'm happy to talk about it later if there are any things people would like to talk about. Over. Thanks.
Thank you, Ahmad. That was coming from a nutrition background myself. This was like listening to the most beautiful sound to know all the different work that FAO is doing with UNICEF and other partners to ensure that gender inequality in rural areas with regards to nutrition and food security is addressed, especially around, for me, the importance of women's participation, their active participation, and knowledge in knowledge exchange activities, and to build their capacity to sustain their families as well as their communities. I apologize. This little munchkin here is all over me. I've tried to get him off of me. I apologize. But something that I think, and this was mentioned in one of your last slides, was the work on radio. Since women are so underrepresented in all forms of media, representation in radio in particular has a profound impact in countries where community radio constitutes an important platform for expression, debate, and dialogue, particularly in rural areas. So thank you very much. With that, I would like to move on to our next presentation by Dr. Chemtai Mungo. Dr. Mungo is an assistant professor of obstetrics and gynecology at the University of North Carolina in the United States. She was born and raised in rural Kenya, and her research is focused on improving access to resource-appropriate cervical cancer prevention in sub-Saharan Africa, with projects currently based in Kenya and Malawi. Dr. Mungo's presentation today is focused on current research and efforts to increase access to cervical cancer screening screening and prevention in rural settings in sub-Saharan Africa, including the use of patient-collected samples for screening, using community health workers to increase screening uptake, and linking screening to treatment in communities where women live. Thank you, Dr. Mungo. Please, the floor is yours.
Thank you. Thank you, everybody, for having me. I'm really happy to be here and happy to share this work that I'm really passionate about, and that all of us who are working on equity for women, and especially rural women, have an incredible opportunity to be able to make a difference. I'll take the next slide. I have no disclosures, and I'll take the next slide. So in context, I'll talk a bit about why cervical cancer provides an incredible opportunity to pursue equity for women and rural women. And I'll talk about some of the work that I am doing and opportunities for health systems serving women all over to make an impact. So when we talk about health inequity and a disease where one lives has a significant impact on their ability to succumb. Cervical cancer is one such disease where there's significant inequity in who gets the disease and who ends up dying from it. Let's go back, please. Thank you. So this is a map showing the disproportionate burden of women who die from cervical cancer. Looking at in the United States and North America, less than 2 per 100,000 women die from cervical cancer. While looking in sub-Saharan Africa, for example, and Southeast Asia, significant burden with as many as 75 per 100,000 in Malawi. And women in rural areas in particular bear the greatest burden because of lack of access to services. Many people might have heard of the pap smear, which is a test that's routinely or historically has been used to screen for cervical cancer. And it was introduced in Western countries in the 1930s. And that resulted in a precipitous drop in death from cervical cancer, which is why it's very rare for a woman to die from cervical cancer in a health system that works. However, there's been an inability to get these services to women in rural settings, which results in this disproportionate burden. I'll take the next slide. This is a technical slide, but basically tells us that there's many cancers for which medicine still does not understand the etiology or how it happens and hence treatment. But cervical cancer is not one of them. This is one where it's actually quite preventable. And the reason is that we know that infection with HPV, which is a very common virus, is what results in precancer, which there's a long period where a woman will have precancer, which is where we have time to intervene and to prevent progression to cancer. So unfortunately, in rural settings, and particularly in sub-Saharan Africa, Southeast Asia, 90% of women are still dying from this disease. And in fact, out of about 600,000 women who die from cervical cancer each year, 90% come from rural settings or countries that have been unable to provide these preventative measures. I'll take the next slide. This is a critical opportunity for equity for women. And in 2018, thanks to a confluence of factors, a lot of research has gone into how we can bridge this gap and address this inequity. The WHO had a global call to eliminate cervical cancer with goals that by 2030, we should get 90% of girls all over the world to be vaccinated against HPV, which is what causes cervical cancer, with a goal for 70% of women all over the world to have access to screening, and 90% of those who have had screening and have been found to have precancer to have access to treatment. We know that with access to vaccination, screening, and treatment, we can actually eliminate this disease. And Australia, which was a country that was the first to adopt HPV vaccinations, actually en route to eliminate cervical cancer such that there'll be no woman dying from it. Unfortunately, a lot of countries in sub-Saharan Africa still have quite a long way to go. But again, we have a lot of opportunity based on the science that we have now to move that needle. So primary prevention with HPV vaccination is key. And in this map, we see that while a lot of countries in North America and South America have introduced the HPV vaccine, as of 2020, only about 30% of sub-Saharan African countries had a national HPV vaccine program. Similar to the COVID vaccine, unfortunately, there's a lot of inequity in access to vaccines. And for a long time, these vaccines had been really expensive. But there's been a lot of work to negotiate prices. And a lot of countries are now starting to introduce HPV vaccination. And our goal is to get 90% of young girls, girls 10 to 15, to be able to get vaccinated to prevent them from getting HPV. There's a lot of research now that's showing that one dose of the vaccine, as opposed to the traditional 3, can actually be effective, and this can significantly increase access. Next slide. For most women, living in rural settings who have never been vaccinated, The key to preventing cervical cancer is access to screening and treatment of precancer. And this is really the crux of why such few women in high income settings or in urban areas are able to prevent this disease. It's because they have access to screening where you can find the precancer state that can be treated. So unlike high income countries, most women in rural settings are served by non-physicians. Often the health system or the health post nearby is staffed by a nurse. So a lot of science has been working on how do we get screening to be done by non-physicians? How do we increase access to treatment, screening and treatment that doesn't involve multiple visits, knowing that women are often coming, traveling 2 or 3 hours to get to a health facility. They have multiple other demands. So how do we reduce the number of times that a woman needs to come to be able to get screening and treating? And again, how do we get services closest to women, and knowing that women in rural settings are not able to travel to the capital city to get screening? Take the next slide. So this is, again, a critical moment because science has shown us that rather than the traditional pap smear, which was a test that required a pathologist, required a pelvic exam, now we're able to screen directly for HPV, which is the virus that causes cervical cancer. And primarily, not only can we directly test for it, but we've shown that women can be taught to self-collect the sample, and that this can be done in the community, in the home. They don't need to be able they don't have to be in a clinic or have an exam by a trained provider. There's a lot of work to make these tests more accessible and affordable, with goals to drive the cost of this test to less than $5. We have very good studies that have shown that a sample collected by a woman is just as accurate as a sample collected by a physician. And also very good studies that have been done in multiple countries all over the world that show that women much prefer to have to collect their own sample over having collection by a provider. I'll take the next slide. So this is an example of work that was done by Jose Geronimo that sampled women from Nicaragua, India, Uganda, and Delhi, and showed very high acceptability of self-collection. Over 85 to 90% of women, given the option, preferred to have their own sample collection. And this is currently being implemented in many settings that I work in, including in Malawi and Kenya, where we're having women collect their own tests to increase access to screening. Next slide. Again, a lot of opportunity to bring prevention to where women are and not have to wait for women to come to the hospitals, which we know are not accessible. So there's a lot of work now on doing screening within the communities. And this could be as part of a specific campaign on cervical cancer prevention, or a multi-disease campaign where you can do screening for hypertension, diabetes, and with HPV collection, women can self-collect these tests in the privacy of a small tent. And then the next step is linking a positive test to treatment. I'll take the next slide. So traditionally, access to treatment of precancer in low-resource settings has been through what we call gas-based cryotherapy, which is a picture on the left, where you required heavy tanks of gas that tended to run out. They were not very portable. So this also still confined treatments to major facilities, which is not where the majority of women have access to. But recent work has been done, which resulted in a WHO endorsement in 2019 of a portable, handheld, and battery-powered device that's shown on the right, which can offer treatment and is efficacious and safe and can be done by nurses and non-physicians who, again, are the ones who are providing care for most women in rural settings. So now we have access not only to offer screening in the community, but we can also couple the screening with the treatment in the community using a portable device that can be carried, in the back of a donkey, which is sometimes how health workers travel to find women. Take the next slide. So in conclusion, we have an incredible opportunity to really bridge a significant gap in equity for women, which is women dying from cervical cancer. I, as an obstetrician, trained in the United States and did not really care for a woman who died from cervical cancer because the system works so well. But my colleagues who work in sub-Saharan Africa, Southeast Asia, and when I have worked myself, the gynecology wards are full of women who are dying from a very preventable cancer and dying in really with no dignity because of how painful, how morbid a late stage disease is. There's a lot of work following the WHO call for elimination, where a lot of countries, including Kenya and Malawi, where I work, have put up excellent policies to adopt this elimination agenda. But we have a lot of work to do to increase coverage, again, to move services from urban settings to rural settings. There's a lot of opportunity to use digital health to bridge the innovation between providers. A nurse in a rural clinic can consult a doctor in an urban setting using a mobile phone, using community health workers to reach women. And key is to, like we're doing, to continue to do a lot of advocacy and hold countries and health systems accountable so that women are able to access this care wherever they are. And that's my last slide. Thank you all.
Thank you so much. That was a brilliant presentation, and I was particularly struck by this sentence, that it is very rare for a woman to die from cervical cancer in a country where the health system works. I think that's a very powerful statement that you're making. And then the data you also showed with regard to the huge impact on women in the low and middle income countries with regards to mortality from cervical cancer, and within those countries, particularly the impact on rural women, and how there's a need to expand services further in rural areas. So thank you for that great presentation. I would like to now introduce our next speaker, and his name is Mark Emerson. He's an assistant professor in epidemiology at the University of North Carolina, USA, at Chapel Hills Gillings School of Global Public Health. He's interested in meaningful research that focuses on, first, integrating biology and access to care in addressing cancer care inequities, and second, improving American Indian Alaskan Native cancer outcomes. He is Diné, Navajo, and Jimez from the Navajo Nation. Indigenous women and rural and tribal lands face unique exposures that lead to chronic health conditions and additional barriers in cancer care. These women need to be particularly considered in designing interventions within cancer disparities research, in reducing detection and treatment inequities. Dr. Emerson's presentation will focus on provision of intercultural approaches to cancer services for rural Indigenous women in the United States of America. Over to you, Dr. Emerson. Thank you, and it's great to have you with us.
It's great to be here. So I'd like to extend my gratitude to the organizers and to the panelists. I'm just really honored to be here, and to the guests in attendance. I'm also really honored to share this space. So good morning from North Carolina, United States. And I, again, Mark Emerson, Assistant Professor of Epidemiology, the Gillings School of Global Public Health. And so I want to start off by sharing just the land acknowledgement. So I am in Orange County, in Durham County. And so this is where University of North Carolina, and Duke University sit. So this is the traditional lands of the Okinichi, the Ino, Saponi, and the Tuolani people. And so these are unceded territories for which people have lived for generations and have kin networks and have been violently displaced by the colonization of the state of North Carolina. But we have indigenous nations here today living and thriving with the Lumbee, Eastern Band of Cherokee, and Saponi nations within this region. And so I just want to start this off on kind of the page of being mindful of whose land we are on, and in this case, the territory that they're contesting from the state and federal government. And so we also recognize the federally unrecognized tribes that also live in this area as well. I'm going to, that's the slide here. I'm just kind of getting oriented here, so apologize. And so I also wanted to start by acknowledging traditional Navajo protocol. So I'm Navajo, I was born in the Navajo Nation. And this picture I'm sharing here is of my family farm and my house back on the Navajo Nation. And so I just wanted to, I guess, start with this tone of introducing this practice, traditional practice of introductions, which is really trying to start off on a tone of relationality and kinship. And so that's something that I want to do as a central theme, both personally in my professional identities, and kind of bringing that into these research spaces in a way that I think can ground and enhance all of our work that we have been so fortunate to hear among the other panelists so far. I think it allows us to be more fully ourselves in these roles that we play within research and within the community. And so this practice is related in relationality and kinship, and applies to me as an individual and how I want to interact with y'all. And then to follow some of the research and those who are impacted by our research. So ya ate she ya Mark Emerson nishne asena abithni basha chin ma ide shkijani de shanale toaglini de shache aquatalkane. So I also was thinking about this in some of the opening themes as well. And so the Navajo tribe traditionally are matrilineal people. And so kind of starting off on the tone also, you know, we really think that as a matrilineal people in our introductions, how it kind of translates is I introduce myself through my maternal bloodline. So, and then the translation roughly is something like born for, and then I identify my father's side. And so I think that's important in thinking through what that relationality looks like and what those kinship systems look like. And at the core, I think they're matrilineal. And so I think overall setting the tone, as stated earlier in the introduction of this panel, that women and girls are agents of change. And so I think this is kind of rooted traditionally in thinking about this specifically within our tribal context of seeing these, you know, 7 generations out, the women and girls as leaders of change in really times that are needed for thinking about how that relates to climate change, how that relates to sustainability, how that relates to food sovereignty, sovereignty in general for a lot of tribal nations here in the United States. And also, as my presentation will show, it also relates to health and chronic disease. So I'm going to talk about the research, but I kind of wanted to offer a wrapper for why this is important. I think that's something that I'm trying to bring into these spaces of talking about research, because I think it's important in the context of what we're talking about. And so this phrase, Sanageb Hoshon, in the Navajo language translates something to like the life force for the reason for being and becoming, and the pathway for continual learning and renewal of aspiration. And so these derive from our ceremonial context. And I think this is important just to mention to you all, to share this with you, I think, and lean into that a little bit, because it does provide this equitable framework. And it also provides this non-static process, philosophy, and orientation that I think can guide us, that when is practiced, it provides a framework, both in the research and community setting, both in home life, both in academic life, or professional life, or living in harmony, beauty, and balance. Within the community and with the natural world, which I also think is important, and overall fosters responsibility, fulfillment, and cultural well-being, which I think is an important component when we talk about chronic disease, especially in the context of accessing cancer care. And as we've heard before with some of the other panelists, when it comes to what that dignity can look like, especially in end-of-life care within the cancer reality spaces that are late-stage disease or uncurable disease. And so I think this can ground and kind of guide some of the work that we do. And I see this kind of as a blueprint to frame out research in a real way, right? I think thinking about what sovereignty looks like for Native tribes has a lot to do with indigenizing what research can look like, or decolonizing what that is. And so I think this really can challenge or be a way to address what cultural complex settings can look like and what research looks like in those settings. And also really as just a real way, like as a like legit way to do research, right? And so I think like being on the shoulders of other Indigenous scholars who've gone on before me to kind of blaze those trails, you know, this paradigm of Indigenous storytelling needs to be added and heard to the research paradigm as indigenizing and decolonizing approach. Or as Bell Hooks has said, this kind of theorizing through autobiography is kind of illustrating this importance of storytelling. And so I just want to use that in this first half, really to just use that as a roadmap to really frame out some of the research questions that I'm interested in. And the larger umbrella of what this looks like is how can we improve American Indian Alaska Native health by what's measured, by measures that are meaningful or hold value to the community itself. And so that link always has to be there. So this blueprint kind of looks like, how do we go about doing that, right? Like, how do we gather that knowledge? Like, those methodologies can draw from both Navajo epistemology and Western academic methods. And so I think that integration is important. It's not this othering, or it's not this either or. It's not this pitting of traditional versus modern, or Western versus indigenous all the time, right? Like these methods can be mixed and draw from both of these valuable learnings to gather knowledge. And all this impacts how we interpret data, how we like give that dissemination back to the community. And it's all informed by the critical lens of our worldview, of our lived experience that we've gone through, that shapes the very questions of how we do the research and the methods that we use. And so I just want to quickly go over just when we look at what we're looking at is just kind of a breakdown regionally of the United States by state and by county. And then these dark blue counties are counties that are adjacent to, that have tribal lands, that are adjacent to tribal lands. And so altogether, we're looking at over 570 federally recognized tribes. And I just want to just highlight this to show the non-monolithicness of this, right? So there's just great diversity and heterogeneity within each of these tribes, having different cultures, having different language, having different norms and geographic regions, which is important, which I'll point out for environmental exposures when it comes to cancer, or what leads to cancer, detection of cancer, and kind of through the whole cascade. And so also important to note is the unique association that these tribes have with healthcare. And so I often highlight my own tribe, just coming from my lived experience, when I can speak to more directly. For the Navajo, that's treaty-based. And so for delivery of healthcare, that's important. And so you need to be a member of federally recognized tribe or live near these tribal lands in these dark blue areas. So you can imagine not being close to these Indian Health Service facilities can create greater travel distance, which is important to think about when accessing care. And I also want to highlight that the majority of, so there's this watershed, right? So the majority of natives live in urban areas. So you can see here, it's about 3/4. So using myself as an example, me being here in North Carolina, originally coming from the Navajo Nation in New Mexico, it's for reasons of school, right? Or upward mobility for a job, which I think is really driving this proportion here. And among those who are in urban areas, as you can see on the insurance status part of the slide on the right here, they have the lowest rate of private health insurance, and they have really high rates of being uninsured, which is a critical component when we think about accessing cancer care outside of these Indian Health Service units. So early on, we did look at what these disparities can look like for certain cancer sites. And I'm going to kind of go through these slides here a little more quickly in the interest of time, but if you have any questions, I'd be happy to address them. One thing that we found is that when it comes to our Native women for breast cancer, these mortality rates are higher after we adjust for age and for certain disease characteristics that are also endemic in Native populations, such as diabetes and heart disease. And we still see that our Native women are dying more often. And so one thing we wanted to look at was initiation and adherence to certain treatments. And so adjuvant endocrine therapy is more broadly thought of as any oral anti-estrogen medication that's usually prescribed for 5 to 10 years. And it's prescribed because it greatly reduces the risk of reoccurrence of breast cancer and mortality, especially among HR positive breast cancers. And so this is important to look at because for a lot of other women of other race ethnicities in the US, these rates are overall declining, but that's not true for Native women. And while this particular research has been done, it hasn't been done within Native women. And so I think that's always kind of this part of the invisibility or lack of, or kind of other like category when it comes to this breakout by race ethnicity. And so particularly zooming in on Native women is important. And so we used a data source that was urban from Kaiser Permanente, Northern California, which is a stable population of close to 4 million active members in the Bay Area. And they have linked data sources to it's an integrative healthcare system. So they have linked data to pharmacy. So this was able to give us, rich information when it comes to date of prescription, pills prescribed, date of refills. So we were able to track that over time within the stable population. And so I'm going through the methods quickly just to show basically what we found here. As you can see that when it comes to Native women with their starting treatment, it was particularly low when we break this out by race. And again, just highlighting that the particular data line of Native women is usually kind of in this other category, or it's this footnoted, like too small of numbers to include in our analysis. So here we're particularly focusing on this. And then when it comes to our follow-up period of 5 years and that adherence to cancer treatment, we see here that Native women had the lowest rate. So when you think about combining both this initiation, lack of initiation, and lack of adherence together, it's 71%. So I think of this as a treatment gap here of the total underutilization. You can see that being the lowest compared to other race ethnicities. And I think this is particularly important. The thing I want to really highlight here, right, is that we're looking at women who are in a city, who are a population particularly selected for a greater likelihood of adhering or starting cancer treatment. And it's particularly important to note that, right, like other Native women with lower or additional barriers, right, going over that private health insurance or lack of private health insurance, or who live in more rural or tribal locations, which is that about 1/4 of Native women, that these results here are probably biased towards a null in the overall experience of Native women who lack those things more broadly. And so in ways I want to highlight that this study really, I think, points out a best case scenario for Native women in terms of access, yet we still see these huge disparities, right? And so that's kind of the underlying point that I wanted to make. And also in closing, I just want to show you geographically where the Navajo Nation just superimposed over the state of North Carolina that I'm in. So it's a large land base, 27,000 square miles, which is about half the size of North Carolina. So I just wanted you to keep that in mind, because the Navajo Nation is the largest reservation in the United States. Again, 27,000 square miles. And we only have 13 grocery stores serving that area. So when we think about access to food, when we think about what food security highlighted in the beginning of this webinar, what food security and nutrition looks like, what health looks like, here in the stars on the left side of the panel here, you see our Indian Health Service units, which are our hospitals. We only have 8 hospitals, and those don't include cancer care. So when we think about health, when we think about land and other resources, when we think about agency, when we think about labor, when we think about resilience in the context of climate change, which I'll mention briefly in a second, like these are the disparities that we see. And on the right, leaning a little bit into my personal example of family members that I've had to be a caretaker for who have died from cancer, they receive their cancer care, their medical, surgical treatments, their workup in Albuquerque, New Mexico, which was a 3.5-hour drive. So we from anecdotal personal experience, these are the amount of lack of access and commitment, I guess, to transportation. And so thinking about Native women who live on tribal lands, these geographic barriers include remoteness of tribal lands, infrastructure, right? So thinking about internet, thinking about paved roads, often in our community, when we try to do, mobile screening for breast cancer, we encounter just non-paved roads, right? And so we can't access a lot of these areas that are really remote and rural. Transportation, financial costs to access cancer care, provider scheduling, availability. So these all create these disparities, I think, is my underlying point that we see in these observed either detection of cancer, starting cancer treatment, and also finishing cancer treatment, which overall we know affects mortality. And so I just wanted to end on these other things that also relate to it on this resilience of the context of climate change and fragility. These are very fragile structures here. So these are taken, so a colleague, a Diné colleague at the University of Chicago and I wrote a commentary in the American Journal of Public Health, and she took these photographs here. And so currently on the reservation, there are only 40% of households with no running water. So they rely on hauling water. And this is a source where they haul water from for both human use and livestock. And this is just an example of community messaging here that is saying it's not safe to drink. These are what we're confronting in these legacies of structural racism and settler colonialism, especially within the context of COVID-19, where we see here that even running water, just access to water isn't there. And so I just want to make the point, again, we're going back to one of my previous slides of my farm. In the back here, you can see this volcanic structure that's called shiprock. And then here in the slide, you can see it here. These legacies, this is the Department of Energy from the 1960s. There was a spill that still hasn't been cleaned up. It's just been fenced off. And you can see in the sign here, both in Navajo and English, that it says, not to drink the seep water from here. And a lot of these don't have signages. And quickly here, what I'm showing you are abandoned uranium mines. So between 1940s and the mid 80s, the United States government extracted roughly 30 million tons of uranium ore from the Navajo Nation with leases from our tribal government. And so there have been a lot of spills, and there's over 500 abandoned uranium mines currently. And so I mentioned these because these are important exposures, as you can imagine, during that time period that have led to these effects, and also highlighting kind of this traditional messaging here that's targeted more within our community with the traditional Navajo bun this woman has. But just to highlight, there's a million things that can go wrong of harmful effects of uranium. And so these legacies of that violence against our environment on our land is there. And so I wanted to just end on this idea, and I'll just kind of leave this up for a second. I'm ending here just to mention that this Navajo-centered knowledge will continue to play efforts in confronting infectious disease and confronting chronic disease and well-being, and thinking about how we can imagine new approaches as an Indigenous framed public health intervention, specifically framed from a matrilineal point of view, I think is really critical. And that integration to how we approach research, sharing kind of these guidelines or potential applications that we can consider across sections of health policy, environmental stewardship, disaster preparedness, cancer care. So thinking about what a relational approach could look like based on traditional knowledge, again, going back to the beginning of that philosophy of harmony, beauty, and balance that can be integrated into kinship systems that can foster responsibility, inclusivity, unity, compassion, and a kind of nonlinear thought of how we consider broader community, family, and relationships with the environment and with others, and how that can be within research partners, and viewing what that relationship looks like with the land and with people as our relatives, and kind of giving clarity to what questions we're asking and how we gather knowledge and interpret data. And so I just want to leave this for thinking about how we can prioritize relational approaches to cancer health, health in general, chronic and acute, and to our environment, and how if we kind of don't do this and rely exclusively on Western epistemologies and methodologies, often that's entangled in hierarchical frameworks that will continue to uphold notions of individualism, secularism, patriarchy, and have this fragmented not really holistic view of understanding self and kin relations. And so I just wanted to frame this out in a more broader context of our conversation today. So thank you.
Thank you so much, Mark. That was a wonderful presentation. And in recognition of your relational approach, I would also like to acknowledge that most of my education was obtained in Ottawa, Ontario, which is unceded Algonquin Anishinaabe territory. And that further from that, I also grew up in Guatemala, and there are several linkages that we can make with regards to the situation of our different Indigenous communities. I think also that the point that you made about the health effects of uranium on pregnant women really adds to Ahmed's presentation earlier, pointing out the generational impacts of, in his presentation, he was mentioning nutrition and food security, but here we're also talking about pollutants in our water, in the food that we eat and drink and share in our families and homes and communities, and how that relates also to climate change, and seeing ourselves coming back to your presentation, not as apart from the world, communities, and land that we live in, but also very much a part of it. And that working together, looking at how our environment affects us and how we affect the environment, there's a different path forward to looking at health and services, but then also taking care of the land that allows us to prosper, or the opposite in this case. So with that, thank you very much, Mark. I would like to now introduce our next presentation, which will be given to us by Associate Professor Ozden Godemir. She graduated from Karadeniz Technical University, Faculty of Medicine in 2002. She also completed her specialization in education in Dokuz Eylül University, Faculty of Medicine in the Department of Family Medicine in 2016, and a PhD at the Department of Physiology in 2016 at the same university. And between then and in 2018, she completed her compulsory mandatory service in Isparta and became assistant professor at the end of that time in 2018 at Izmir University of Economics, Faculty of Medicine. She's now working as an associate professor doctor at the same university. Dr. Gökdemir will present on capacity building of rural family doctors on gender responsive service delivery from the Wonca perspectives. Doctor, over to you.
Thank you very much. We can just go through the next slide. What will we talking about? There are some questions that we can answer about it. The ones are what we mean by institutional capacity, how can it be developed, and also how can it be controlled to the rural family physician and gender equity. Next slide, please. Well, in Turkey, there's a definition of rural, but it is just more years ago. We made a research about burnout and rural family physicians, and we find out that this definition is not just settled down with the participants who are just working in rural. And then we just work on it, that it is in our country, or it is the definition is just something not clear in other countries too. We can go to the next slide. And find out that, and not only for family physicians, but also for surgeons, that in other countries, rural definition just differs to each other. Like what? We can just say that it is just a non-metropolitan areas. We can just say that lack of sources. We can just say that just over or far away from the center. We can go to the next slide. But after COVID, what happened? The truth is, after the COVID, we just can't see the rural in the urban areas if we just think about the lack of sources. And then just go to the next slide. The pandemic and syndemic, just the things that have we faced with the COVID-19. What I mean, there are some people who have got jobs and their salary, they just face with overloading and maybe moving. But also there will be some people, and there are some people who lost their jobs, and this pandemic make them in the syndrome of economic burden. Next slide, please. So do we need a tool to just go to use this or to overcome these burdens? Community-oriented primary care can be a tool for that. Next, please. What is community-oriented primary care? Well, the first thing is to define the population that we are working with, we are living in it, and then just to identify health needs of this population. So the prioritize the health needs, which could be done in a few days or which could be done in a years. Then implementation of intervention programs that have been just taught with the other participants in this panel, and to implement into community involvement. Next, please. So we should just define the community. We can just say that here today, we are a community. We are just working on how to overcome these burdens. So we are a community. We can characterize the community and just prioritize the things. And then after all those things, we can evaluate ourselves if the things has got good or not. Next, please. It has been first used in South African physicians Sydney and Emily Clark. They are just making a zoo tribal reserve in Palestine, and just seems that they get some benefit from what they do. Next, please. I just want to give another success story, but it is also a tragic one. Ürgüp is just the middle, next to Sparta, in the middle of my country in Turkey. There are lots of balloons, and now today it is so touristic. But more years ago, next slide, please. Although it has been told about the beautiful horses lands near Niğde and Aksaray. Next, please. There were lots of sudden deaths. Nobody were living much more than 40 years old age. Teachers, and these teachers are important because they are from the Village Institute graduate teachers that UNICEF has been accredited. And now in my country, I'm so sorry that there are no teachers like graduate in that way, because they are capable of not only the teaching system, but also arts and also health products or health needs of their villages. They thought that there's something wrong in here, and so why people are dying at those ages. Hacettepe University and their stakeholders just begin a thesis about it to understand what the problem is, and the story began. We can go to the next slide. As you see in this picture, after the houses, there are some cave-like places, and these cave-like places are just after the volcano eruption. And so there are lots of minerals have been there. The villages were using these places for winter time to get not so cool, and for summertime to be cool for their products, for the food management. We can go. And they found out that the thing that people are dying was not tuberculosis, was not destiny, or was not the Kronos said. It is about asbestosis. Asbestosis just made the mesothelial epithelial cells inflammatory, and afterwards we can just see the mesothelioma at that part. It is something environment that has been distracted their lungs, and so they are dying. Next slide, please. But it is not only the story in Turkey, in Ürgüp, but it's also, there are lots of advertisements at those times in eastern part of our world that's saying that you can use asbestosis to save your buildings. It is very cheap, it is very good, and blah, blah. But the truth is, it's just making us sick. Let's go. Next slide. So in here, we can just think about the community healthcare workers, the teachers, and also the community that we can work together in the teamwork. Next slide, please. So in here, we can just say that communities could have problems just like people. In here, we have got food storage, and it is very cheap, it is very useful, it is their place to live in. But also this behavior just made people ill. And sometimes community has got problems, so the people will be ill too. Like what? Racism, breast ironing, or genital mutilation, and the others. So to define the part of the community that you're living in or you're giving service in is very important, because by this way we can understand which is the real problem and which we could just have to handle as soon as possible. Let's go. And other, well, this is again another example from my country. It is where I changed my slides because of this reason. This was an article that we had made with about gender-based violence, and we figure out that you have got rules, you have that policy, but if you don't use them, if people just put it in the practice, you will lose lots of people. Salah is one of them. She is 16-year-old and has been murdered because she didn't want to marry at 16-year-old with another man. And it was in the middle of the country. You may say that it is like the ballad of an old song. Everybody heard her voice, but the murder just came to face. So what can be done here? Next slide, please. We should think about it. Yes, there was COVID, and yes, there were rules, and there were lots of societies and security about that. And the father and the families has got some rules to make it with the police, but she has been murdered. What was the problem? Next slide, please. Next. In here, we just figure out that domestic violence is the community's illness. So by this way, the first right that World Health Organization and all the organization has said is to be alive, has been just taken off from this 16-year-old girl. How can we just make it by ourselves? Can a family physician could just save this girl? Of course not, because it's a teamwork. It is to heal the community and to practice the rules. Next, please. So we need awareness and know-how about adolescent health, legacy, health law, and the physicians that do know and could use these things. Social work stakeholders and also policymakers could be in the box with us. Next, please. So I just want to give another good example about capacity building of rural family doctors. One of the great examples is Türkan Saylan. She is also a rural physician. She works as mandatory and as obligatory in the rural places of Turkey. And we just worked about hygiene and prevention and therapy part of the medicine. Also, she made another thing. At those times, there was no dermatologist as female, because it has been taught that being in dermatology is a man job. The truth is, as we are talking about science, we can just say that it is a man job or women job. It is our job. And then she just, the next slide, please. Then she just worked on leprosy hospital, because leprosy just didn't change anything with the gender. It is the dermatologic illness that could be seen in men, children, and also women. So World Health Organization has got a consultant for her too. And leprosy hospital has just come with her with the country hour too. The next, please. Another thing has been happened, because Türkan Saylan has just made another association for the support of the young girls too. This is the thing that happened with the how can we advocate for the gender equity? Because if the girls could be educated, and if the educated girls could have their own salary, and if they could manipulate their salary, so this will make a change. Cardamom is a flower. It is just being faced to the sun in most of the parts that could be seen in winter. Although it is a hard job, Cardamom could make it. So in Cardamom projects, she just made lots of girls to get educated and to gain our own money. We can go again to the next slide. At the funeral, there was a word that I want to share with you. Please stop asking yourself, why am I born a girl? Because aim at becoming the best you can be, could be best. This is very important, I think, because there are lots of things happening with gender violence or equity. Please stop asking, why am I doing this? Just begin to do the best you can. Next, please. So education will be very important for us. Economy is also, but the use of economy is truly important. Why? As Marx says, you can work in the agriculture, but if you can't get the money or the security as a woman, that means you're not there. Nobody can see you. I worked in Rize, early cancer center diagnosis place, and we saw that there are lots of women who are just saying that their job is being housewife. And being housewife is not on security, nothing to do with social security. Afterwards, when we ask what do they do in their daily time, we learned that they are working in agriculture with tea places, tea gardens, because they are collecting tea and the other agricultural things. That means they are doing the hard work, but they are not seen on the scenery. So because of this reason, health and inequity could be seen. The problem is in here to get the present in our minds. Next, please. So for education of the GPs and, or we can say family physician in rural area, clinical toolkits are needed to train the manuals and cultural sensitivity. As I said before, it could be the problem for breast ironing, or it could be because of marrying in 16-year-old. So what is the problem should be seen, and the content of curriculum for the medical education is needed. Next, please. Summary is, let's define the community and define the needs of the community. Structure the framework, and we don't need to walk alone. Yes, we can be role model and try it, and some people would like this too because they are using the other disadvantaged people. But we can just do it with the other stakeholders and policymakers too, and also the healthcare workers. Next, please. This is what analysis that could be seen that when we made something, just look at inside, get the reflection. Did it work? What were the opportunities? Or did we make really something good or not? What did work? What didn't? By this way, we can go forward. Next, please. And while we are talking about the butterfly effect and the other things, the truth is we are making with the individual level, like family physician, we are just getting a holistic touch, but also if will be healthy as our planet is healthy too. And nowadays our planet isn't healthy. So when we are talking about health for all, it is also including our planet too. Next, please. When we are talking about asbestosis, it just takes at least 100 years. So to improve something wouldn't be just like in one touch. It should be structured and should be in an institutional way. By this way, it won't be about only one person. It will just go through and improve. Next, please. Thank you very much. I also want to share you with a poem. While there is something wrong with Ukrainian and the other things, we can just say, to live like a tree alone and free and in border fruits like the forest, this hearing is ours. Because shut the gates, don't let them open. Let's stop to destroy the main certitude to the man. Thank you very much.
Awesome, thank you so much. So I appreciated your presentation of different aspects related to capacity building of rural family doctors on gender responsive service delivery. And I appreciated how you covered a range of environmental and social determinants and key issues for strengthening health services, including GBV services for rural women. I'd like to now, as we're going a bit over time, I'd like to now hand over to Bruce Chatter, who's chair of the World Organization of Family Doctors, Wonca, their working party on rural practice, to please give us some closing remarks. Over to you, Bruce, please.
Thanks so much, Theodora, and also Evelyn for convening this with us tonight. It's a great partnership between WHO and rural Wonca. We think it's excellent to see the policy at such a high level and the workers on the ground being able to have this partnership. So thank you very much. I think the speakers tonight certainly brought out the rural disadvantage and certainly the added disadvantage for women in rural areas, but also gave us great hope, I think, looking at some really wonderful initiatives. So Majalo Liwa, thank you very much for the discussion around first-time young mothers. I think obviously we'd hope that in future we can help them prevent those pregnancies, but at the moment, certainly to help them have the inspiration to, you could see the happiness and the joy on their face of being in control of their lives with resources, facilities, education. Ahmed, thanks very much also for recognising the great strengths that women have, the wealth of knowledge that they have with respect to nutrition, and once again being able to empower that and try and give them that leadership and recognise that leadership that they've got in so many ways. I think that was quite inspiring. Chamtai, thanks also for recognising that patient empowerment is important. Having innovative ways of particularly the self-collection for women that aren't so threatening, but then also getting the vaccinations out. I see some chat around the cost of the vaccinations. That's obviously a very real topic now with COVID, as well as the HPV vaccine, but also then the need for services. And I think the example of some of the treatment options that we're looking at, something that's possible in rural areas with simple equipment, but also trained staff. And I think that's where we come in again and again, trying to look at making sure we have properly trained people, hopefully grown from those communities to be able to do some of that work, whether it's doctors or community health workers or nurses. Mark, thanks for us also. Thanks for reminding us about Indigenous people. I'm in the lands of the Woolly people, the Aboriginal people in this area, and we recognise their heritage in this place and their leadership in this place, and it's just so important to have them involved. It's a double disadvantage sometimes for rural women in Indigenous communities, and I think it's important to recognise them and grow them. And we've certainly got our own Aboriginal health worker in our practice that we've grown as a local person into someone of great status in our community now. And I think having women rise within their communities because of their knowledge, their power and their passion for their communities is important. Austin reminding us about community orientated primary health care. I think that's the secret of rural primary health care, rural family practice, is that it has to be about community and with community. We like to see, as I said, local people grow into those workers and the team to be around them in that community. And it's important to be able to grow, particularly women in those teams, to be the role models. I think sympathetic men powerful and very competent women in those communities as health workers and family practitioners can be great role models. And I think we often underestimate the power for people in those situations to create change in communities and to be agents of that change. So thanks very much to all our speakers. We'll go to the next slide and just remind everyone of where we've been and where we're going. We've had some great sessions over the last few months from rural proofing, social participation, policies, intersectoral action in agriculture, information systems, the inequalities, and tonight very much focusing on women. For the final one, we're looking at innovations, and I think that's appropriate that at the end of this series, we try and bring it together in such a great way to look at how rural areas can do it in a very rural friendly way so that we get good outcomes for rural people. Just thanks very much to all the women who are involved in rural health. I see Amanda Howe on tonight, who's been a great leader in Wonca as a woman, and really showed how important women are in rural health. Thanks very much, Austin, and all our other speakers. We look forward to catching up with you on the 24th of March with another exciting group of panelists. And thanks everyone for your interaction tonight in the chat. So we wish you farewell. I'm off to sleep. It's nearly 1 o'clock here. So for some of you, you're just starting your day. So thank you and good night, good morning, good day. Bye.
So thank you very much, Bruce, and thanks to all of our speakers and thanks to all of the participants. I know there have been quite a few questions that have come forth and exchanges via the chat. And I do, if there's any pending questions, because we have to close the event now, as also our IT services are closing. If you don't mind, just if you want to further exchange with anyone, directly, please, include your email so there can be direct contact if there's any pending questions from that chat. And otherwise, I look forward to seeing all of you next month at our next webinar on the 24th of March, and that will look at innovations in service delivery in rural and remote areas, as Bruce was saying. And when we talk about innovations, we're not only considering technological innovations, but also social innovations, institutional, organizational innovations. And so we'll be covering different aspects of innovation. So thank you very much, and we really appreciate your engagement today. Goodbye, everyone.
All right.